Okay, so today we're going to focus on the Gonstead full spine chiropractic techniques. Okay, so this is very different from previous Thompson methods. So you should forget about everything that we talked about in Thompson because it's the evaluation concept. The principles are totally so the areas that you have to correct first will be slightly different from Thompson or AMCT. Okay, so we're going to talk about the Gonstead method, and in Gonstead method, we should start from the pelvis and go up. Okay, pelvis, lumbar, thoracic, and cervical. That is the basic concept. Okay, because the weight bearing is always on the SIJ when sitting or standing. In Thompson techniques, we should consider about the cervical syndrome before going to the pelvis. But in Gonstead, we always start from the pelvis. Okay. So the pelvis includes the SI joint and the lumbosacral junction. Okay. So we have to evaluate if the SI joint is fixated or not. If it is not fixated, we go up. Okay. So the first findings that we can tell is if the SI joint is subluxated is by looking at the femur head line. Okay, if the femur head in the X-ray is one is inferior and one is superior, there's deficiency in the pelvic. Okay, and the side that goes up, the higher femur head will be the long leg side, and the lower will be the short because the X-ray is in Gonstead will be taken in a standing position. So the femur head in standing will be lower, and in prone position or supine position without the weight bearing, it will be higher. Okay, so that's how you could um, evaluate. Okay, but most of the times it is very different in individuals. Okay, so let's go to the slides. Okay, so please open your textbook that I sent you, the Gonstead textbook, Pelvis and Sacrum, um, part one. Okay, so we're going to look at the misalignments of the SI joints. Okay, cured. Just a minute, I can't find my. Something's wrong. Just a minute. Okay. Chapter one, the AP ileum misalignment. Okay, so this is the picture of the AS ileum. Okay, we don't actually call it innominate in Gonstead in chiropractic. We call it ilium because the articulation is on the ilium, not the whole innominates. Okay, so we call it PI ilium, AS ilium, IN ilium, or EX ilium. Okay, so if it is AS, the ilium will be superior and anterior against the sacrum. So it will always be elevating up superiorly if it is AS. Okay, so that the iliac crest will be higher than the contralateral side. Okay, so AS means that articulation of the ilium is superior and it is flexing. Okay, in that ways the ischium will rotate posterior and superiorly. Okay, as the sacrum on that side, sacral base will rotate posteriorly against the ilium. Okay, so if it is AS on the positive side, you won't be able to palpate the PSIS. Okay, because the sacrum is more posterior than the PSIS. And also the PSIS will be superior against the S2 tubercle of the sacrum, or the contralateral side of the PSIS. Okay, so it's actually flexing, but it is there is also a superior shear on the AS side. Okay, if it is AS, the sacrum will be rotating posterior against the ilium on that side. So if the AS side is positive, there will be a hypolordosis or a kyphosis. Okay, so some people think that if the ilium is rotated anteriorly, they think it will make a hyperlordosis, but that is actually not true, because the sacral base is responsible for the lordosis of the spine. Okay, the sacral base is the lumbars is on the sacral base, not the ilium. So if it is AS, the sacral base is tilting posteriorly. That means that the low back will be kyphosis or hypolordosis. Okay. So if the patient comes in and has a low back pain and the patient has a kyphosis, a straight back, that is maybe it is due to the AS ilium. Okay. So from P to A, from posterior to anterior view, we call it AP view. The second S2 tubercle of the sacrum and both sides of the PSIS should be parallel. It should be aligned. If it is AS on the left side, this PSIS will be superior against the S2 tubercle and the right PSIS. Okay. Also, the length of the innominate, the whole innominate will be shorter than the contralateral side. Okay, because it is tilting posture anteriorly. Okay. So if it is tilting anteriorly like this, this is neutral, and if it is tilting anteriorly, it'll be flexing. So if it's in a flat view, it will look short. Okay, it will be shorter than the contralateral side. Okay, so the length. Okay, so this is normal innominate. So the length, let's say the height of the superior edge of the iliac crest and the inferior angle of the ischium. We're going to measure the height. Let's say it is normal. It will be 212 millimeters. If it tilts anteriorly, the height will be shorter. Okay, so it will be 208. So there will be a 4 millimeter difference in this case. Okay, so the short side will be AS. Okay, to determine if it is AS or PI, we should look at the AP view from P to A. We're going to flip the X-ray film around so we could see right is right and left is left. Okay. And we're gonna place a dot on the top of the femur head. Okay, so these are the baseline. So we're gonna make a long line from the left dot and the right dot. So this, we call this the femur head line, and this will be the base of the misalignments of the pelvis. Okay, it is not always parallel to the film. Okay, so in this case, we can tell that this film, compared to the film, the femur headline is there's an oblique axis declining on the right side. So the right side will be the short leg. Okay. Okay. So in this case, we can measure the height of the length of the innominate on each side. Okay. So the short side uh, will be AS, and the long side will be PI. We didn't talk about PI, but if it is PI, it will be actually totally different, opposite as AS. Okay, so AS, there will be a kyphosis, and if it is a PI, the sacral base will be tilting anteriorly. Okay, it will be a nutation. It will be hypernutation. That means there will be a hyperlordosis for PI ileum. Okay. The patient's positive side is PI, there will be a hyperlordosis. If the positive side is AS, there will be a kyphosis or a loss of lordosis. And in AP view, the innominate on that side will be longer. It will be longer. So that it will look long because it's posteriorly. Okay. So we have to measure. The PSIs will be inferior and posterior against the sacrum. That's PI side, so that the PSIS on the PI side will be more prominent compared to the AS. Okay, if it is AS, the sacral base will be more posterior than the PSIS, so you won't be able to palpate the PSIS. But if it is PI, there will be a deep sulci on that sacral base because the PSI is rotating posterior, inferior. It will be easy to find the PSIS. Okay, and it will be longer. Also, that the this pubic symphysis on the PI side will be lifting superiorly because the posterior the PSIS is inferior. That means that the anterior side will be lifting up. So if you can't visualize the PSIS, you can tell if it is a PI or AS by the pubic symphysis. This superior pubic will be the PI side, and the inferior will be the AS side. Okay. Okay. So in this case, we draw a line and the femur head. Okay. We don't know which side is positive, but in GONSTEAD, it will always be the body rotation of the L5. Okay, so if it is PL, the spinous process of L5 is shifting to the left against this S1. That means it's PL. That means that the right side will be positive for the SI joint. Okay. So the posterior rotated side will be the positive side that you will be adjusting. You have to remember that. Okay. So if it is anterior rotated, let's say it's the body is rotated to the left, that means that the spinous process will be shifting to the right. We call that PR. And we will never adjust the right side because the right side will be the anterior rotated side of L5. Okay. So the positive side will always be for the SI joint or the sacral base. When we adjust it, it will always be that is rotating posteriorly. Okay. So in this picture, you can't see L5, so you can't determine which side is which. Okay. but you can tell that the right side, the femur head is lower against the film line. Okay, let's say this white line here, squared lines, is the film line, and this purple line will be what, the femur head line. So you can tell that the right femur head is lower than the left. That means this right side is short leg in prone position. Okay. So this is how much maybe it is caused because it is PI on the right side or EX on the right side. Okay. Or the left side may be, the higher side may be AS or IN. Okay. So the finding of AS and IN will be the same. The findings for PI and EX will be the same as well. Okay. So PI and EX will make the legs short. AS and AS and IN will make the legs longer. Okay, so it's a coupling movement. Okay, so now we're gonna use this parallel ruler. Okay, from this what femur headline and bring it all the way up to each iliac crest. Okay, so these lines on each iliac crest will be parallel to the femur headline, not the film. Okay, and we're going to bring the parallel ruler down to the inferior angle of each ischium process. Okay, and these lines on both sides will be parallel to the femur headline as well. So you're going to use this parallel ruler to make it in a right angle against this femur headline and measure the length of the iliac crest and the ischium. Okay, so the left side will be 223 and right will be 226. That means that the right side is long. That is a finding of PI on the right side, or the left side is AS. Okay, and the right side is short because it is PI. Okay, in this picture. Okay, so in this picture you can see the spinous process of L5 here, and you should place a dot here on the center of S1 spinous process. So let's say this is the spinous process of S1, and L5 spinous process is rotating to the right. That means the positive side that we're going to find for the SI joint will be the left side because the body rotation of L5 is on the left. So in this case, both sides length is the same. Okay, it's the same, 247, 247. And the femur head is not tilting. So we won't be adjusting the innominates or the iliums, okay, in this case, because the femur headline is equal and the length of this innominate is equal. So we will be directly to L5, okay? Okay, so another finding that you want to see for AS is that there will be a spongy disc on the inferior posterior aspect of the PSIS. So there will be swelling here. There will be edema here. So you can find the edema below the PSIS for AS because there will be an open wedge here. The PSIS rotating anteriorly and superiorly. That means there will be an open wedge here. So you have to close this open wedge. Okay, instead of opening the superior closed pack. In GONSTEAD, we always think about closing the open wedge instead of stretching the closed pack. Okay, so in AS, the superior aspect is closed. So in massage or body work, we try to stretch the PSIs to go down. Okay, but in GONSTEAD, we always try to close the open wedge. For AS, there will be a edema that is making the fixation. Okay, a chronic edema will make a major subluxation. Okay, in that case, we have to close it. We have to close, and if it is chronic, there will be ankylosis at the SI joint. Okay, here because of the swelling. Okay, if it is acute, it will be movable and it will be very painful for the patient to mobilize the SI joint. Okay, and that will be a contraindication of adjusting it. Okay. So this is a PI change. If it is PI, the innominate, the ilium on that side will be posterior rotated, and it will also be declining against the sacrum. It will be there will be an inferior shear against the sacrum on that side. Okay. So the PSIS will be more prominent, and the pubic symphysis on the PI side will be rotating superiorly on that PI side. Okay. So it will be posterior rotating, so it will be shorter than normal. Okay. So we talked about that. And there will be an open wedge at the superior medial aspect. Okay. So we have to close this superior open wedge. Okay. We have to close this edema. Okay. In this picture, left side 229 is longer, so this will be left side will be PI, right side will be AS. We write the positive side only, so we see the rotation. You can't see it right in this picture, but this spine process of L5 is rotating to the left. That means the positive side of SI joint will be the right. Okay, body rotation is occurring on the right side of L5, so we always write the listing on the positive side. So we have to see the rotation of L5 before evaluating the SI joint. Okay. So the body rotation is right, so we write AS on the right side because it's shorter. Okay. We don't write PI on the left side. Okay. And the pubic symphysis on the right side is slightly inferior against the left. Okay, that is a finding of AS. Okay. Okay, so this is a summary of AES ileum. So some AES ileum is on the side of the shorter innominate. Okay, the length of the innominate will be shorter on the AES side, and produces a smaller projected obturator foramen. Okay, and causes a decreased lumbar lordosis. Okay, so it will be more like a kyphosis or straight back. Raises the femur head level. Okay, and causes spongy edema at the posterior inferior margin of the sacroiliac joint, and leaves the sacrum posterior on the involved side. Okay, so the PSIS won't be able to be palpated. PI ileum is opposite as AES, so it is on the longer innominate side and produces a larger projected obturator foramen, and causes an increased lumbar lordosis and lowers the femur headline. Okay, so PI will be short leg in prone position, and causes a spongy edema at the posterior superior margin of the sacroiliac joint, and leaves the sacral anterior on the involved side. So the PSIS will be more prominent than the opposite side. Okay. And also there are INEX dysfunction. So if it is an IN, okay, we always find S1 or S2, spinous process of the sacrum, and compare the length of both sides of the lateral edge of the sacrum. Okay. So in this case, A and B, the right and left, is equal. So there is no IN or EX. So if one side is IN, that means that the opposite side will be EX. Okay. So in this case, A will be longer than B. The left side is longer than the right side. Okay. Between the PSIS or the lateral edge of the sacrum. Okay. So that means that the left side will be laterally subluxated. The PSIS will be laterally subluxated. We call it EX. Okay. That means there will be a flare in, because if the posterior PSIS goes out, ASIS goes in, so there will be a toe in supine position. IN on the right side will be medial, PSIS will be medial to the center, so it will be closer. That means that the ASIS will be lateral. That will be a flare out flare. That in supine position, the patient will be in toe out. Okay. So in the X-ray, we place it on the sacral tubercle S1 and draw a straight line down towards the pubic center of the pubic symphysis. Okay, so this straight line down is on the left against the center of the pubic. That means that the anterior aspect is rotating to the right, and the posterior aspect is rotating to the left. So the left will be no, the posterior PSIS on the right side will be rotating to the left. So is the left side will be rotating left. Okay, so it will be shifting together. Okay, so there's no such thing as both sides EX or both sides IN, because it is connected here at the pubic symphysis. Unless there is a tear at the pubic symphysis. If one is IN, one is EX. Okay. The positive side is the side that the body of the L5 is rotating. So if it's PL, the right side will be IN. Left side will be compensation. So we won't be adjusting the left side. If L5 is PR, we'll be correcting the left EX and leaving the right IN alone. Okay. Never adjust both sides. Okay. So we only adjust the side that the body of L5 is rotating. Okay. So let's say the body is rotating to the left, so we adjust the left EX. Okay. After that, a lot of non-chiropractors or fake chiropractors adjust the opposite side. Okay. What happens to L5? It's going to make a secondary subluxation by a trauma that the manipulated made. So the rotation of L5 will be rotating more to PR. Okay, and there will be secondary nerve impingement on both sides, left and right. Sometimes it will paralyze weakness. Okay, it will make everything worse. Even if the pain goes away, that is just paralyzed. Okay, it's not treating the patient at all. That means that it's like this from superior to inferior view. We could see that the whole innominate is rotating to the right against the sacrum. That means the right side will be IN and left side will be EX, and the pubic symphysis is rotating to the IS side, IN side. Okay. So if we correct the side that is positive, both sides will move. Okay. Okay, so that's the positive side finding. So there are changes in the there's such thing as compound subluxation of SI joint, such as ASEX ASIN, PIEX, PIIN. Okay. Like I said, AS and IN will make the leg longer. PINEX will make it shorter. What if it is ASEX? AS makes it longer and EX makes it shorter, so there will be no difference in the femur headline. Or PIIN. PI makes the leg shorter, IN makes it longer. So if both aspects are equal, there will be no difference with the leg length height. Okay. Okay, so we'll talk more about the leg length later on in the course because we don't have enough time. We'll talk about the X-ray analysis when we see each other in India, okay, in Delhi. Okay, so let's go on to the palpation part and the adjustment part. Okay, just a minute. Okay, so first thing we have to do is see the patient in a standing position if the patient is tolerated to stand. See the height of the ilium, okay, in iliac crest. The left side is high, right side is low. That may be due to the short leg on the right side, okay, or long leg on the left side. That means that the left side may be a superior shear because of the AS or IN, okay, on the left side, or the right short leg side, the declining side of the nominate will be PI or EX. Okay. EX only will decline and make short legs. Okay. PI only will make it short as well. But if it is PI and EX, it will make it very short. Okay. Or ASIN, both will make it very high. Okay. AS will make it high, IN will make it high as well. Okay. Long leg. But if there's AS and IN, both, it will be very high. Okay. And that will make compensation of lordosis. Okay. Okay. Lordosis. So let's say the patient's leg length is very short on the right side, and the doctor tries to make a shoe lift on the right side to make it equal. The only thing that is contraindicated to make a shoe lift is when the lumbar rotation is occurring on the opposite side, or the curvature convex is on the opposite side. Okay. By shoe lifting up, the lordosis, I mean the scoliosis on the right side, the curvature tends to go back to normal if we bring it up. Okay. So if it is there's a curvature like this and the right leg is short, we make a shoe lift on the right side that makes the scoliosis straight. Okay. So what if the scoliosis, the convex, is on the opposite side and the right side is short? If we try to lift the ilium up by doing a shoe lift on the right side, there will be more curvature on the lumbar and make the scoliosis more prominent. It gets worse. Okay. So when we do a shoe lift, we have to consider how the lumbar is curved. If there's a convex on the short leg side, it will be indicated. If the convex is on the opposite side and the short leg side has a concave, it will be contraindicated to do a shoe lift. Also, if the right side is short and the rotation of L5 is rotating to the right, when we lift the leg up, the lumbar will tends to rotate towards the opposite direction, okay, to make it straight. But what if the short leg side is anterior rotated like this, okay, the short leg, the ilium that is dropping, is rotated anteriorly and we try to lift it up, it's going to get worse. Okay, it's going to get worse. The rotation is going to get worse. Okay, so we have to consider the convex of the scoliosis and the rotation of L5. Okay, so it's only indicated when the convex side and the rotated body rotation side is on the short leg side. If the convex and the body rotation of L5 is rotating towards the opposite direction, it will be contraindicated to do the shoe lift. Okay. 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 So now we have to see the rotation of L5. Okay. So we're gonna mobilize this L5 spine process on sacral base. Okay. S1. Compare which side it goes more. Okay. Or we can also palpate the mammillary process on each side, which side is deep and which side is shallow. Okay, we only adjust the shallow side. Okay, if it is PL, the right side will be shallow, left side will be deep. So we will adjust the right side, never the left side. Okay. Okay, so even if it is the right side is AS or PI or IN or EX, the positive side will always be the side that the lumbar is rotating. Okay. That is the first thing we want to see. And from lateral view in standing position, if it is hyperlordosis, that is finding of PI ilium. It is rotating. Because the innominate is rotating, ilium is rotating posteriorly, that the base is tilting anteriorly and will make a hyperlordosis. Okay. And if it is AS, there will be a kyphosis. Okay. If it is AS, the sacral base will be rotating posteriorly. That will make a straight back. Okay. It will be a kyphosis, loss of lordosis. Okay. Also, we can find the edema at the medial to the PSIS. If it is superior, the edema is superior to that, it will be PI. If it is inferior to that, it will be AS. If there's a edema swelling at the superior and inferior, the whole medial aspect of the PSIS, that means it's a EX, okay? Flare in. If it is IN, there will be swelling at the anterior articulation here. Okay, so you will feel the patient might feel some pain in the groin. Okay, they always say they have hip joint anterior of the hip joint, like the inguinal ligament here. They feel some pain there when they try to flex their hip joint. Okay, when they try to flex their hip joint over 90 degrees, they will feel something that is stuck that makes it painful when we try to fix it. That is a sign of IN because it is flared out. The opening on the anterior aspect is opening and there was swelling there. Okay, there will be pain there. We can't actually palpate it, okay, because it's deep inside. We might think it is a inguinal ligament problem, or maybe we might think it is a psoas trigger point. Okay. So if we leave it alone, if it is chronic, we have to adjust it before the ankylosis gets more prominent. Okay, get worse. Okay, so we try not to make the patient suffer from ankylosis. We could do the adjustment. So now we have to have the patient in a sitting position and palpate the PSIS and medial to PSIs. Okay, and flex a little. Have the patient to flex a little bit and rotate the body like this. towards the PSIS so that the sacrum will be rotating away from the PSIS if it is normal. Okay. Now we're going to rotate towards away so it gets closer. We're going to see the gapping between the sacrum and the PSIS by doing the rotation test. Okay. Okay, so if there's fixation, the PSIS will move along like this when we rotate the sacrum. Okay, but if there's no dysfunction or hypermobility, the PSIS will be stable, even though the patient tries to rotate. We try to rotate the sacrum on the pelvic. Okay, so the positive side is the one that is fixated. In Gonstead, we do the sitting rotation test. Okay. We put 2 fingers at PSIS and medial to the PSIS and try to open and close by rotating the body. Okay. The side that moves together is the subluxated side. We don't know if it is PI or EX or AS or IN or not. Okay. Okay, and now we can have the patient in prone position, find the height of the length of the leg, and see which side is short. Okay, the short side may be PI or EX, or sometimes maybe the ankle or the knee or hip joint has problems. So we can't differentiate by just looking at the leg length. Okay, so Gonstead doctors doesn't look at the leg length at all. We only see the X-ray femur headline. Okay, because the femur headline has nothing to do with the ankles or the knees. Okay, but the leg length in prone position, there's a lot of meat on the feet, so we can't actually see the difference correctly. Okay, that is due to Gonstead only. In AMCT and or Thompson, we see the leg length as a tool by seeing the reaction of the muscle tightness, okay, or contraction of the muscles. So we can see the difference because it changes. Okay. In Gonstead, we don't think about the neurological effect of the muscles because the neurological effects of muscles is not responsible for the subluxation itself. Gonstead always thinks that the muscle contraction is due to the compensation of the joints. Okay, so let's say it's a PI ilium, so the hamstring might be pulling it posturally, but sometimes it is anteriorly tilting, so it will be neurological contraction like Thompson. So muscle are trying to compensate the articulation. So what is making the subluxation is not the muscles. It will be the ligament, inner articular ligaments. Okay, so ligaments is what stretched out, and there's an edema. Okay? And if there's an edema, it won't be able to move anymore. Okay, if it gets chronic, it will make an ankylosis. Okay, so we have to push away, bring out the inflammation, edema by closing the open wedge, okay, in the articulation. We don't stretch it, we close it, okay, to push out the inflammation liquid, okay, fluid, okay, and that is constant. Very different from diversified techniques. So, okay. So like if we want to fix PI, we don't, PI is like this. So in other techniques, we try to stretch the inferior ligaments like this. Okay. But in Gonstead, we don't stretch the inferior ligaments. We're going to close the edema at the superior aspect. So we have to imagine to close it. Okay. Not stretching the inferior. Okay. Okay. So we're going to talk about the closing the open wedge when we do the spine as well. Okay. But today we're talking about the SI joint. It will be the same. So the articulation, we're trying to close the open wedge where the edema is. Okay. The inflammation fluid, we have to bring it out, okay, compress it out, and it has to be very fast, okay, very fast and specific, okay, without tearing the ligaments, okay. So the direction of force, the image of PI or AS or INAX is totally different from what we do when we do OMT or diversified techniques. Okay? Osteopathy is always about stretching the muscles, okay, in direct techniques. But in Gonstead, we always close the open wedge without stretching the ligaments or the muscles. Okay? We have to relax the muscles in order to adjust. Okay, so we don't stretch. We close. Okay, that's very important to know if you're a chiropractor or an osteopath. Okay, so it's totally different. Okay, so and the word full spine means Gonstead, okay, or Palmer style. Okay, so we have to see the full spine to see if this is major or not. If there's a scoliosis like this, we have to see where it is, where the cause of the scoliosis are. Okay, okay, so we have to see this full spine before doing any corrections. Okay, get it? So if there's a tilt at the sacral base or the tilt at the femur head, the lumbar and the thoracic and the cervical will be compensating the tilt. Okay, so if there's a tilt at the femur head, it will be because of the SI joint. If there's a tilt at the sacral base, we have to consider if it's an L5 problem or a sacral problem. Okay, so we're going to talk about sacrum next week. Okay, today we're going to focus on PI and AS only. Okay, and we're going to talk, if we have time, we're going to talk about IN and EX. Okay, so if we find a positive side, we could do we could measure the length of the innominate. Even if the patient doesn't bring an X-ray film, we could measure the height of the iliac crest and the ischium process. The longer side is PI, the short side will be AS. Wider side will be IN, the narrow side will be EX. Okay, so like if it is narrow, it is the PSIS, the thumb is PSIS and my middle finger is ASIS. If it is EX, it will be narrow. Okay, if it is IN, it will be wide. Okay, if it is PI, it will be long. If it is AS, it looks short. Okay, PI long, AS short. Okay, IN wide, EX short, narrow. Okay. Okay. So in Gonstead, we don't actually do the motion palpation of the SI joint. We see the rotation of L5 and consider the height, the short leg or the femur headline by X-ray. If not X-ray, we could see the greater trochanter, which side is lower, which side is higher. If there's a difference in the height of the greater trochanter, it's due to the SI joint problem. Okay? The low side will be PI or EX. The high side will be AS or IN. So we don't actually have to do the motion palpation moves. We only do the rotation test to consider which side is positive that we want to adjust. Okay. Oh.
Hi, ma'am. Good afternoon.
How are you?
Fine, ma'am. How are you,
Hello,
ma'am?
ma'am. Hello, madam. Hi, ma'am.
Hi. How are you?
Okay, so patient should be standing normally without closing their knees, just normal stance, like 5 inches leg wide. So we're gonna find the iliac crest height, okay, and compare, okay, and we're gonna find the issuing process. So this is from A to P. Let's see from lateral view. So we're gonna look at the iliac crest height, compare right and left, and we're gonna find the gluteal fold, okay, and the gluteal fold on right side is inferior and left side is superior, okay. There's no difference with the iliac crest. That means that the left side is short and the right side is long. So if right side is positive, it might be PI on the right side. If it's the left side is positive, left side may be AS. Okay, we don't know which side is positive, so we can't tell. So from posterior view, so find iliac crest, the gluteal fold here. So this is higher than the right side. Right side is declined, so that means that the right side is longer than the left. Okay, and we could find PSIS here, S1 here, and I could place my thumb on each PSIS, and my middle finger will be at the lateral aspect of her hip. So I can, my thumb and my middle finger, I have to widen my right hand compared to the left. Left is narrow and the right is wide. That means that she has a PI IN on the right side. If it is PI, the leg will get short and IN will make it longer. So she might not have any difference with the leg length. Okay. So in this case, I can find the greater trochanter, okay, and see the height. I see no difference with the height of the greater trochanter. So if the greater trochanter is equal on both sides, she may not have any problem, or she might have a PIIN or ASEX. Okay, get it? Okay, so this is the first thing we want to do. Now we want to have the patient in a sitting position. Okay. I'm going to have the patient in a sitting position. And we're going to do the gapping test in a sitting position. Okay. So if I want to palpate the right side, I'm going to stand on the right side and find the PSIS with my middle finger. And medial to that, I'm going to find the sacrum. Okay. PSIS and my index finger will be medial to the PSIS. Okay. I'm going to palpate with two fingers. Okay. I'm going to hold her from the anterior aspect of her shoulder with my right hand. Okay. And my armpit will be stabilizing the left shoulder. So I can rotate her body like this. Okay. So now I want to flex a little bit slightly and rotate her shoulder towards the PSI. So in that way, the posterior aspect should widen. Okay. It doesn't widen. Now I want to rotate her away. Okay. Left rotation. It should get closer. But the PSIS and my middle finger and my index finger moves together. That means that she has a fixation on the right side. Always compare from the left. Okay. So I'm going to find the PSIS on the left side. Place my middle finger, medial to that, my index finger. I'm going to hold her right shoulder with my left hand, and the armpit will be stabilizing the left shoulder. Okay. So I could rotate her body like this. Okay. Flex up slightly and rotate towards, rotate away. So when I move her body, my fingers get widened and closer. Okay. It moves. The sacrum moves individually without the PSIS moving. So the left side, she doesn't have any dysfunction. On the right side, it moves together. Okay, it moves together. So there's a fixation on the right side. Now I have to find the rotation of L5. Okay. So it is pretty difficult to do that in a sitting position because the erector spinae will be stiff. Okay. Now I'm going to find PSIS, find S2, tubercle, S1, and L5. it's very easy to find S2, okay? S1 is pretty difficult. Now above that, there will be a L5. It will be in a 30 degrees angle. If you find the spinous process above that, that will be in a 45 degrees angle. That will be L4, okay? So first thing you want to do is find PSIS on both sides. At S2, go up, S1, L5, L4, okay? So if you can't find L5, you find the most prominent PSIs from the inferior to up, okay? And that will be L4, okay? So you're gonna go below that, okay? So that's L5 spinal process is very small, smaller than L4, okay? So I could flex for patient and find the inner space there. So I can palpate L5 spinous process, okay, from left to right, okay, and the sacral S1 from right to left. I stabilize L on the sacral base with my right hand from right to left, and then try to move the spinous process of L5 from left to right. Okay, I'm going to do the opposite direction. L5 spinous process moves easily from right to left, okay, but is fixated from left to right. So that means that she has a body rotation to the right. So we're going to adjust the right side. If you can't palpate this doing the spinous process test, we can contact on the mammillary process or the transverse process of L5. Okay, and which side is more prominent? Left side is deep compared to right. Right is shallow. Okay, so I can say that the spinous process rotates to the left is PL. Okay, the body rotation on the right side. So we're going to find the right side. Okay, see the right side. So the right side is long, so it is PI. It is wide. That means it is IN. Now I'm going to have the patient in prone position. What's supposed not to do? I'm going to see the leg length, and she has no leg length difference. Okay. If she has a PI, the right will be short, okay. And if it is EX, it will be short. And right is positive. If she has a AES, it will be long. IN will be long as well. Okay, but because she has a PI that makes it short and IN that makes it longer, there's no difference with the leg length. Okay, this is different from the things that we discussed in Thompson. Okay. Okay, so this is the only thing we do in GONSTEAD. We don't do the gapping test. We're doing the palpation part, motion palpation part. But to see the length, okay, like in a prone position, to see the height of the iliac crest, rotation of L5, okay, by the mammillary process, transverse process, or the spinous process, okay. Now, in this case, the spinal process L5 moves to the left, but does not move to the right. That means that the spinal process rotates left. So the positive side will be, the body rotation side is the right side. Okay. Now we can palpate PSIS, firm contact, and the left side is superior and it is not prominent. I can't hook the left PSIS well. But the right side is very prominent because it's posterior rotated. Okay. And the medial aspect of the sacrum is deeper on the right side. It looks as though it is an AI sacral base on the right side, but actually the right side PSIS rotating posteriorly against the sacral base. Okay. Now I could find the gluteal fold. Okay. And right side is superior, left side is superior, and the right side is inferior. Okay. You can actually visualize the gluteal fold. Okay, So her left side, right side is long, left side is short. Now I could find the PSIS, and if your finger is long enough, I could grab the ASIS, which side is wide, which side is narrow. Okay. So the right side is very wide, the left side is narrow. So it's right side is IN, that's why the left side is rotated towards EX. So she has a PIEX on the right side. Okay. So for the adjustment part, we could do it. I'll show you how to do the adjustment one more time. Okay. But just as a sample, I could do the adjustment for PIEX on this side in a push manner and a pull manner. So in a push, we have the patient's positive side up in a side posture. Okay. We have the EX side down. Okay. So for PIEX in a push technique, and put a pillow here. We have the patient in a side posture with always the feet off the table. Okay. So her feet should be off, ankles should be off the table. Flex without rotating her body and find the movement of the SI joint with my inferior hand as I move the hip joint into flexion. Okay. I could pull her arm, shoulder towards the PSIS like this, and she's gonna hold her body like this. Okay. I'm gonna pull her shoulder away from the PSIS to make a stretch and rotate her whole body without rotating towards me. We call it roll in. Okay. Stabilize her femur with my superior leg and my inferior leg. Okay. So I could be her what blockage like a table when the patient is in a prone position. The table will be blocking her the movement. But in side posture, there's nothing to stop my thrust. So I have to stabilize her anterior aspect with my body. This. Okay. So if it's a PI, I'm going to pull the tissue slack up and use my pisiform contact. If it's a PI, I'm going to stabilize her body like this. Okay. Traction away from BSIS as it's going to be a very firm contact, not to jam the jam the joint here, articulation, and the thrust is towards B to A, I, S. Try to close the superior edema. Okay, very fast and very short. After the adjustment, I take my hand away very slowly because it's not a recoil. Okay, for EX, my hand should be medial. Okay, for just EX, I could adjust medially for EX. If it's a PI EX, I could my hand will be medial to adjust the EX. And as I do the torque, I'm going to torque it so it will be medially. So my hand is in a right angle. So the torque will always be trying to make it straight. Okay. So this on the right side, if it is EX, if it's PIEX or ASEX, it will always be rotating doing a torque towards CW. Okay. If it is IN, my hand will be in this angle, PIN, and it will be always CC. For AS, it will be CC. ASIN, it will be CCW. EX, it will be always CW. Okay. Okay, for EX on the positive side have on the opposite side. This is a pull technique. So her ankles should always be off the table. Now I'm adjusting the table side. The right side is on the table side. Okay. So I'm going to flex her superior leg as I see the movement on the right side, not the left side. Okay. Excuse me. The setup will be the same. Okay, so I'm going to pull the shoulder towards the right PSIS as I stabilize her shoulder away, the top side away from PSIS. Okay. I'm going to rotate her whole body first so I could contact with my inferior hand pisiform lateral to the PSIS because it's EX. I want to pull it like this. Okay. And I want to close. As I pull, I want to close the medial edema by doing a torque. As I do that, I want to, the right side, it's an EX, so I want to do a clockwise torque to close the open wedge, okay? So I'm gonna lift up and contact. So my hand will be in a sandwich between her innominate and the table. I'm going to bring her on so I could pull like this. As I do that, I'm going to do a torque to CW. Okay. This is CCW, CW, okay? Stabilize, and I'm going to use my knee on her femur so I could push posturally as I pull with my right hand, okay? So it's going to be very fast, okay? So that is the PIEX, pull. I'll show you how to do that some other time. Okay. For AS and IEM and others. Okay. But today I just want to, after the adjustment, always do the evaluation by doing the rotation test. Okay. First, you want to see that the this is left side, so this rotating test. And the right side as well. Okay, so the right side, it was moving together, but now it's moving individually. Okay. The rotation test is negative now. Before it was positive because PSIS and sacrum rotated together when I rotated her body. Okay. And also you could do have her standing up. Okay, that's a little. And I didn't tell you about the lordosis, but she didn't have a hyperlordosis or hypolordosis because she had a PI and IN. I mean PI and IN. Okay. So actually, I showed you adjustment for EX, but it's usually PIEX. I didn't show anything about her IN. Okay. We'll do that later on in the course. But I only adjusted the PI part. So I want to see the height of the iliac crest. The gluteal fold is very straight now because the left side was inferior, but it's actually straight. Okay. And the width, I didn't do anything about the width because I just did a sample. I didn't do the thrust actually. But as I corrected her PI, her IN and EX went away. Okay. So her major was a PI, not the IN EX. So sometimes that occurs. Okay. And I could see her leg length. No, her leg length was equal, so I don't have to do the post evaluation because it was negative. Okay. If it was positive, I should do a post evaluation of the leg length. But it was equal, so I don't have to do that. Okay, that's about it. Ayun. Okay, so did you understand it? So you should go back into the textbook and read it very carefully. So there are a lot of what styles of Gonstead actually. Okay, for the torque and everything, there's a lot of types, and the things that I'm telling you in this basic course is based on the Gonstead Chiropractic Science and Art book. Okay, so there's other Gonstead books, but and the seminars that I went was a little bit different from this, but let's just go back to the basics. Okay, so this is based on Gonstead himself. So if you go to other Gonstead seminars, some people say a little different things. They're not wrong. Okay, they're updating things. Okay, and this is the original. Okay, like Thompson, there's a lot of types of Thompson evaluation techniques as well. So in this Palms Chiropractic College, we're always giving you the basics. If you know the basics, you go to advanced. Okay, but if you don't know the basic, you can't do any advanced. Okay, so there are a lot of advanced techniques as well. And those are actually postgraduate course for chiropractors. So don't go to postgraduate course even because you're not even a postgraduate. Okay, so you have to start from the basic. Okay, don't start from the advanced. You get mixed up, and that's not going to help the patients. Okay, so Gonstead is actually postgraduate, anyways. That's why we started from the basics. Okay. Okay, so any questions? So if there's any questions or anything doubts about the SI joints that we discussed today, you could write in a WhatsApp so we could discuss it next week. So we're not finished with the SI joint yet. We're continuing little by little, okay? So if any doubts about the things that we discussed today, we could just do it next week, okay? And do some other evaluation for the IN, EX, and the sacral base as well. Okay. Okay, you guys good? Any questions? Good. Okay, so just study the materials, okay, and don't go beyond. Just stick to the things that we're studying right now. Don't go too much because you're going to get complicated. You get lost. So we're doing the SI joint. So just focus on the SI joint for the guys. Okay. And we'll talk about the lumbar when we study lumbar. Okay. After the SI joint and the sacrum. Okay. Don't go ahead. Okay. It's not going to do any good. You're going to forget about it. Okay. So just believe in me and stick to us. Okay. Okay. That'll be all for today. Okay.
Thank you, sir. Thank you.
Yeah, we'll talk about AMCT.
Thank you, sir.
Thank you, sir.
Yeah. Take it easy, okay? Goodbye.
Thank you, sir.
Thank you, sir.
Thank you, sir. Bye, sir.
Thank you. Goodbye.
Bye.
Thank you very much, sir.
Thank you.
Thank you.
Bye.
Bye, sir.
Bye, sir.
Bye.